Okay, I'm going to present interesting case of percutaneous closure of an overworking AV fistula. So this is a 42-year-old male patient, hypertensive, known patient of chronic kidney disease. The patient had a AV fistula done in his left forearm 3 years back. For the past 1 year, his forearm and the arm have been swelling massively. His gradual and massive enlargement of his left arm and forearm and, for the past 1 year. And the patient presented to us with symptoms of congestive cardiac failure for the past 3 months. Examination-wise, his vitals were stable. The patient was in congestive cardiac failure with a gross enlargement of his left arm and forearm with a thrill of the AV fistula present over the arm. The ECG and 2D echo findings were nearly normal. It's an ejection fraction of around 55%. We did a cardiac cath plus a fistulogram. The cardiac output was around 9.5 liters per meter square with a very low systemic vascular resistance. The fistulogram was done. I'll show you the pictures a little later. So the diagnosis was a high output cardiac failure with a right ventricular failure due to an overworking AV fistula in the left arm. So considering the patient's local and systemic problem, that's a swelling of the arms and the congestive cardiac failure, we thought the closure of the AV fistula would be the solution for it. We thought of closing the AV fistula with a stent graft. So this is the picture of the left arm, which is grotesquely swollen. If you compare with the right arm, we can see the left arm is even larger than his own thigh. So this is the picture which is there. This is done 2 months back. So we took the patient to the cath lab. The patient arm was so huge that we had to make the patient sit next to the cath lab table. The whole procedure was done with the patient sitting with the arm resting over the cath lab table. So this is the first picture of the angiogram which was done. So this injection into the, we have taken a 10 French sheath and put it in the brachial artery in the antegrade way. So this is the injection done through the sheath in the brachial artery. So we can see that the So this is the filling of the antegrade flow into the brachial artery, then the vein is filling immediately. Just after the fistula, we can see that the antegrade flow below into the radial artery is very slow, probably because the vein is rapidly filling back. Show you the next picture. So, yeah, we can see this. There's a rapid filling of the cephalic vein just after the brachial artery is filling. The antegrade flow is very less. We tried to cross it with a 3-5 wire. So finally we managed to cross it with a thermo wire. We can see that there is no antegrade flow. We are just seeing the arterial filling followed by the venous filling retrogradely. There is no antegrade flow. So considering that we wanted to put a stent graft which is of a little higher profile, we thought we should dilate this. Passed a PTCA wire next to it. We dilated with a routine coronary balloon. Then we took a stent graft. This is a barred fluency plus stent graft of 10 into 40. So this we deployed at the site. This is the injection. So this is the deployment of the stent graft. This is the injection post stent graft deployment. There is no filling of the vein. There is a sluggish antegrade flow, but definitely there is no filling of the vein here. So this is post procedure. Patient was discharged after 3 days. So patient has come for follow-up after 2 months. So this is the pictures after he has come for follow-up. The left side ones are the pictures where which was taken 2 months back. Presently there is a gross reduction of the swelling which was there. So very small, virtually the hand is the size of the normal right hand. There is some skin excoriation there. Here we can see the comparison here. Patient's congestive cardiac failure has improved. Patient is stable now. He is on CAPD and his arm swelling is dramatically reduced.
How long the time between the clearation of fistula and your intervention?
Creation of fistula. The fistula was done 3 years back. Patient was on hemodialysis for 2 years. Then for the last 1 year, since they noticed this swelling, he's developed this swelling for the past 1 year, so they stopped that. Patient was on COPD for the past 1 year. So he's been advised by the nephrologist to go for this procedure, but delayed and finally came to us with congestive cardiac failure 3 months back.
So this stent graft you put through the radial artery.
No, sir, we have punctured the left brachial artery.
Okay.
So because we took a 10 French sheath, punctured the left brachial artery, and just took a direct injection through it. We could see that it's a very faint antegrade flow. It was stenosis also was there. So passed a thermovire and just put the graft over that. Just a direct antegrade. Patient was sitting next to the cath lab table. We couldn't make the patient lie down. His hand was size of the thigh actually.
Yeah, that's a
Dr. Padmanabh?
very well done case.
Dr.
Thank you.
Padmanabh, can I ask you?
Yes.
How does this compare with the surgical procedure? It's a purely peripheral iatrogenic arteriovenous fistula.
Yes.
In terms of the cost, efficacy, outcome, would a surgical closure not possible?
The vascular surgeon has seen this patient, so he was not comfortable doing any procedure for this patient. They themselves have done the AV fistula, so he was referred from nephrology. Nephrology.
What does the literature say?
Literature says that generally they close AV fistula if it's non-working. For overworking AV fistula, not many cases have them. I've just reviewed the literature as such. There are some cases, but such a hugely swollen, massively swollen arm, I've never, didn't find a case in the literature as such. They have closed AV fistula once the dialysis part is taken care of. The patient is on CAPD like that. But for a local problem, in addition with a high output failure, not many cases of surgical closure. I couldn't find any other case as such. Yeah, we have been giving antibiotic therapy for him. We continued the antibiotic therapy.
If it was overworking, why there was no forward flow?
I couldn't get you. Yeah. Why there was no forward flow? Probably there was a stenosis at the junction of the artery. That was a radiocephalic AV fistula. So from the radial artery into the cephalic vein. So probably there was a stenosis. I am not sure about it. But the antegrade flow was sluggish once we put the thermovire.
In fact, physiologically, what has been seen that you see that this is such a huge limb and hugely vascular limb. It is more indication that probably the distal part of the artery is stenosed. Most of the time, without doing that, probably it would have not
The
been.
probable reason could be that the whole flow is going off into
Going
the
to
vein
the
rather
vein
than
side,
antegradly.
correct.
So that's the most probable reason. So from the artery, it's directly going off to the vein without the antegrade flow. Thank you.